Hello, everyone. I'm Ariana Familiar. I am a data science supervisor in the imaging unit at D3B at CHOP. I work on an interdisciplinary team, and our main initiatives include data coordinating for multi-site consortia, one of the primary ones being the CBTN, as well as developing analytical software tools and workflows to apply to the imaging data and ultimately to support ongoing research and clinical trials. What I mean when talking about imaging data is primarily radiology imaging, and those are MRIs collected as part of routine patient care. So our pediatric brain tumor patients often will undergo several MRIs over the course of their treatment journey. During those MRIs, they enter the scanner. Several images are often collected, and those images are used by radiologists to make interpretations of the patient's status and then report those findings and make recommendations to the patient care team. And so oftentimes this occurs over, like I said, the course of the treatment journey. So during time points such as baseline assessment of for diagnostic purposes, as well as treatment planning, surgical planning, and post-surgical assessment of resection. MRIs are also continuously taken during treatment, follow-up, and are used for response assessment and monitoring for progression or recurrence. And so because patients undergo several MRIs over the course of time, this amounts to a whole ton of data. And this is a whole lot of data collected clinically. It's not just large in terms of its size and the storage and computational resources required to process it, but it's also a lot of data that is potentially valuable and mineable for creating predictive analytics. All right. So what I mean by that is that those images can be aggregated, they can be taken and prepared and input into artificial intelligence models, machine learning models for model training. And those models then, once they're built on a lot of data and they perform well and they're validated, can then be used to perform and aid in some of those clinical tasks that radiologists face. So that can include detection of a tumor, diagnosis of cancer histology, correlations with mutational status and other molecular characteristics, as well as predicting prognosis and risk estimation, as well as monitoring and estimating tumor growth over time. And importantly, once those models are built and validated, they can then be integrated back into software tools that can be used in the clinic to bolster radiologist assessments, to aid ultimately in clinical decision-making and impact patient care. So to date, this translational work and the success of these models has primarily been found in adult populations, in adult brain cancer populations. And the same amount of progress has not been seen in pediatrics. And there are several reasons why that could be, but the primary and most obvious one is access to data. So while there's been several large-scale initiatives to collect and make available adult imaging data for brain cancer patients, the same has not been done in the realm of pediatrics. Imaging data also, especially that which is clinically collected, is very messy. It requires a ton of data structuring and preparation in order to be used for model building. And there's a lot of domain expertise. There's a lot of technological and computational resources necessary in order to use imaging data in practice. So for the next part of this talk, I'm just going to focus on data access and how the CBTN in particular is leading the way in breaking down barriers to access to imaging data for research and clinical trials. And just to stress the importance of this, so today, predictive analytics and model building is common across, pretty much every domain. So regardless of you're in whether you're in advertising or marketing or politics, media, sports, people are building out predictive models based on data. And really, the power in building these models and the performance of the models that are built all depend on the data that they're trained on, the data that they learned off of. So you typically need a lot of data, you need representative data, and you need data that's going to be usable in the context that you're attempting to apply it to. So in order to build clinically applicable models, it's necessary to collect and to centralize and make available clinically collected data. And so the CBTN is leading efforts in this context for imaging data by generating a centralized imaging data set. So centralized data is nothing new to CBTN and the people in this room. However, the imaging data set in particular has really progressed dramatically in the last year. So what this looks like is CHOP acts as the data coordinating center. Sites send their radiology images where we then house it long-term. We store it, we de-identify it or anonymize it, and make it available to researchers and clinicians and people who want to use the data on a platform called Flywheel. And so that is an outward-facing platform. People can access it in a web browser. And so, and I'll be talking a little bit more in detail about Flywheel later on. So to date, for the CBTN, we've had 4 sites that have contributed data. A lot goes into that, just figuring out essentially what infrastructures and systems exist at different sites because it's not completely uniform, and then developing workflows in order to essentially get data out of radiology department systems and onto a platform that can essentially, a software platform that we can use to then share between sites in a secure manner. So we've had to work really closely with different sites to be able to accomplish this, and with some really amazing clinical coordinators and project managers and site admins who have worked really hard to be able to set up these workflows. We have collected and continue to collect MRIs retrospectively for our CBTN cohort, and we've also in some cases been able to set up a framework for prospective routine polls. This is also a just continuously ongoing development. So we are assessing how platforms that exist could operate interchangeably to reduce the kind of barriers and resources and platforms that we see that have really made it hard for a lot of sites to send images to another site. Once the data arrives at CHOP, we store it in a cloud environment. We then also use cloud-based compute, and we have been able to, over the last year, create a process that can scale with just the volume of data that we're receiving. So it doesn't matter if we're receiving 10 images or 1,000 images, we can process them efficiently and rapidly. So once we receive images, they are prepared for upload and subsequently uploaded. And so that can involve things like de-identification to remove PHI and map subject identifiers to the images. All right, so that brings me to the metrics of the CBTN imaging data that we have collected to date. So as shown earlier, for a little over 1,000 subjects, we have nearly 12,000 separate time points or exams. And these exams and subjects range many different cancer histologies. And these numbers are just ever growing. So we expect to reach 12,000 and just surpass that in the next month or two. Looking more discreetly at the exams that we've collected, the majority are MRIs. Again, these are all clinically acquired MRIs that were collected as part of routine standard patient care and patient protocols. Of those MRIs, the majority of them are brain and spine, images of the brain and spine, as you can see here in orange and gray, and they span mostly infancy and early childhood into adolescence. Of the MRIs, we have various scanners that the images were collected on. So those, for example, the manufacturers and the magnetic field strength of the scanners. And this just shows that we have captured a lot of variance in site and scanner properties that's crucial for, again, building out models that can perform well across these different settings. We've reached almost 200,000 total images or total sequences that we've acquired because they're clinically collected. The majority are structural, with some advanced MRIs as well. Of the structural images, a lot of them are T1 and T2 weighted. A lot of subjects have diffusion weighted imaging as well with corresponding ADC maps and other derivative data. And many subjects also have the structural both pre and post gadolinium contrast injection. So that's a ton of data. It's not necessarily something that could be easily parsed by a single person or even a team. And so in order to allow people to be able to use this data and essentially filter to the data, the exact files and time points of interest, we have built out a essentially a website where users, this is completely public, so anyone can go to it, and users can essentially narrow down and filter the available imaging data based on some of the properties I just showed you, as well as other imaging related properties, clinical factors, and molecular sequencing availability. To access the imaging data, researchers and clinicians go through the same request process. So they submit a research request. Once that is approved, then they are given a user account with an email address that they provide, and then they're given access to the data on Flywheel. So I hope I've showed you just a glimpse into how the CBTN is really leading the way in providing access to imaging data for researchers and clinicians that can be used for building out models that ultimately will perform predictive analytics. They'll provide richer characterizations of disease, and with the goal of ultimately impacting patient care. Just to underscore the importance of this, this is the only pediatric brain tumor imaging data set that's currently made available for use. A little bit later on in the section, we'll talk a little bit more, myself and my colleague Anahita Fatih Kazruni will talk a little bit about how we are also addressing challenges in the data management and in the technology space. And again, just to stress, so the goal here is to both bridge data and analysis tools and workflows to allow researchers and clinicians to use this data, but also to build models that will persist over time and models that can be ultimately translated back into the clinic to impact patient lives. And so with that, I'd like to just thank the, again, amazing research coordinators, CRCs, CRAs, project managers, radiology admins at these sites that have really worked hard and worked collaboratively to send data, as well as sites that are gearing up and are on the precipice of sending us data. I'd like to thank my teammates and key members of other units at D3B that really all together have accomplished this work.